Hello, everybody. Thank you so much for inviting me to be here, to be part of the European Harm Reduction Conference of this year in Prague. I will talk mostly about women who use drugs surviving multiple situations of violence and vulnerability, that they find it very difficult to enter or adhere to social and healthcare networks. They are often excluded from specialized services, including the ones focused either on drugs or in gender-based violence. The first ones are mostly for men. Women only represent 15%. And for example, the harm reduction services end up not being safe spaces for them, or they are not designed to meet their needs and their interests. On the other hand, we find that the services that are focused on gender violence don't accept women who use drugs, or they are expelled for these services just because they use drugs. All of these end up being a continuous denial of their rights, with lack of optimal options, access barriers, institutional gaps that exacerbates inequality, injustice, and social exclusion. Metzineres, born in 2017 as a festival, as a project, and since 2020 we are a non-profit cooperative aimed to deploying environments of shelters that are exclusive for women and gender non-binary people from a full spectrum of harm reduction perspective, intersectional feminist perspective, based on human rights and community strategies, also part of the social and solidarity economy. It's a really innovative model that has proven to be reliable, pragmatic, cost-effective, where we have been answering to the heterogeneity of the members of Metzineres. What we found is that, of course, we began to give a room to the women who use drugs, but we know that the use of drugs is not their main problem. In fact, one of the things that we see is that they use drugs to cope with other factors of vulnerabilization, as just to give you some numbers, like 71% are homeless, 54% are roofless, 21% are sex workers, but 33% are doing survival sex, around 20% are racialized, 34% have migratory experience, and around 13% have regular administrative situation. 44% are facing mental health diagnosis, 30% have been in prison, and most of them are living with HIV and Hep C or both. As you can see, we have around 300 women engaged in Metzineres. Most of them are cis women, around 12% are trans, but also 5 to 7% are non-binary. When we look at the drugs that they use, mostly they use injected cocaine or smoked cocaine, crack cocaine, methamphetamines, heroin, but what is more common is the polyconsume. what we saw is that it's true that they have a lot of them are struggling with the drug use, but all of them are facing multiple situations of violences. They are overrepresented with the women that survive violence during childhood, also during adulthood. They have been surviving violence from their partners, from their families, from the nervy context, but also from unknown persons. And we cannot forget the institutional or structural violence too, that comes from the stigma and criminalization. Also from, of course, from police, from judicial system, penal file, but also from healthcare and social care networks. All of them, we can see that there are an intersection of these violences or stigmas that come from sexism, ageism, drogophobia, stigma against sex workers, capacitism, male chauvinism, racism, aporophobia, between others. And what we see is that they are not. We have to realize that these women are survivors. They are resilient. They are really powerful women that are able to be creative and to share a lot of knowledge. No, it's because that we put in place Metzineres with different goals. One was to take approach from this intersectional feminism, focus on the person based on the freedom of redefinition, autonomy, straightening, just to improve the physical and emotional and psychological well-being of the women, whatever it means for everybody, for each one. Also, we wanted to reduce the barriers to access or other to different care networks, going where they are at, literally and figuratively, with high quality resources and services that we are trying to provide. Also supporting the women as essential interlocutors. They are the experts on their own realities. It's because that since the beginning they have been part of our team in equal conditions than the rest of the staff members. And also we are being supporting women to interact with politicians, with media, to transform public policy, and also the ideary that accompanies normally the community. We want to reduce this stigma, prejudice, and discrimination, being part of the rest of the social struggles in Barcelona, especially into the feminist movement also, that sometimes forgot the most vulnerable populations. Then we want to make sure that women who use drugs are part of the feminist struggle. And just to give a few ideas of what we do in our daily life, for sure we take care of the basic needs. The women can come to sleep. They can use their drugs in our site, whatever they are using, whatever is their drug of choice, always with the accompaniment of our nurse. We also have social worker, a lawyer, community technicians, anthropologists, artists, and a transdisciplinary team. But we don't want to focus on the assistantialism. We focus on the creativity and the activism. It's because that we include the drug use, but we don't define ourselves as a consumption room, because all the time something is going on. We have workshops of theater, of fanzine, of natural cosmetics, dancing, feminist self-defense. Also, every Friday we have for Paella, that is a community event where the neighbors come every Friday to eat with us a nice food and have some fun. And also we go to all the a lot of events, like to cultural events and walk in the mountain and whatever it takes to build community and to engage with a feeling of belonging to our neighbors, but also to the city. No? We have been really serious about the planning, monitoring, and evaluation process. We want to respect the intimacy of the women or the rhythm. It's because that we never have any questionnaire. But we have our own database where, after having a coffee with the women, where we can share, where they can share whatever they want or whatever they decide, we go to our database, and where we have been systematizing new indicators that are meaningful for them. And we spend a lot of time systematizing their testimonies in this database, just to make sure that we are doing a great job, that we have a positive impact in their lives. And if it's not the case, we can stop fast, because we apply these methods routinely, and every day we check how it's going. Is not a finalistic point of view of the monitoring process. In that sense, we not just can be reconfiguring our actions, but also making sure that we can provide with real information about these women that normally are so stigmatized. I don't gonna explain too much, because I know that we have short time, but here you can find more information. We invite you to follow us to our networks, and also you can go to our YouTube channel to check a lot of nice videos, that most of them are translated in English. Thank you so much, and have a nice conference.
Hi, my name is Katrin Schiffer, and I work for Correlation European Harm Reduction Conference based in Amsterdam. Today, I would like to shortly address some notes on social inclusion and harm reduction. And in my presentation, in my short presentation, I will mainly refer to the results and findings of a European project, the Street Support Project, which we carried out with the different partners. And we actually focused on the development and implementation of participatory and integrated interventions, and inclusive interventions for people who use drugs, but also for people who are homeless. I have included the website, but later on as well. So in my presentation, I will shortly focus on the definitions of social inclusion versus social exclusion. I will give some critical notes on the concept of social inclusion, and also address the ideas and the interconnection between social inclusion and harm reduction, finalizing with some recommendations. Looking to the definition of social inclusion, we see that social inclusion is a process of improving the terms of participation in society, particularly for people who are disadvantaged, through enhancing opportunities, access to resources, voice, and respect for rights. This is a definition of the United Nations, and I think it's important to stress that it is, as such, an ongoing process which requires action from both sides, meaning that also governments and society do have a strong responsibility to develop an enabling environment and policies which enable people to become socially included and participate. If we look to the definition to social exclusion, I think it's important to also address this one, because very often social inclusion is somehow defined as the opposite of social exclusion. It describes a state in which individuals are unable to participate fully in economic, social, political, and cultural life, and also in the process which leads toward this state. And there we see that participation as such is seen as a key element, and it refers to a stimulating environment, and also that it refers that individual skills and capacities are needed, but also economic independence, health, and social support. The whole discussion on social inclusion and the discourse about how governments and countries can somehow develop social policies is in principle in first instance a good one, because it for the first time acknowledged the vulnerable position of marginalized groups. It also acknowledged that there is stigma, that there are inequalities and discrimination. And it also made governments responsible to take action and develop certain policies. On the other hand, there is increasing critical notes. There are some critical notes towards this concept of social inclusion. The most important one would be the narrow focus on economic productivity and paid employment, meaning that for sure we all know that economic independence is important, but focusing on the economic productivity and the paid employment as such only or solely on these kind of things is discriminating in itself, because we need to acknowledge that some people cannot do paid labor work. It also does not acknowledge the fact that there are really bad labor conditions in some countries and poor payments. And it also does not acknowledge the fact that people contribute very often in other ways, like, for example, through volunteer work or other ways to contribute to society. And a second critical note goes on the fact that the main focus is on pulling people over the line towards social inclusion, which without actually really addressing the underlying factors, structures and mechanisms which lead to social inequality. So more fighting against the symptoms and not against the causes or the roots. A third one would be the fact that many policies which are implemented are top-down policies and do not build on participatory approaches, and again push people who are already disadvantaged into a more passive position, which we actually would like to have. And last but not least, there is a lack of intersectional approaches, which are kind of one-size-fits-all policy, which does not acknowledge the fact that people are different and that vulnerable or marginalized groups are not all the same, but it's a very heterogeneous group of people with different needs and also different skills and capacities. So what is needed instead is that we need a diverse and approach which takes into account specific needs, but also, again, the skills and capacities which are there. We also need to detach the concept of social inclusion from the ideal of economic, probably not independence, but in economic productivity and paid employment, towards and come to a more acknowledgement of other productivities or how people can contribute to society and participate. We need to develop intersectional, participatory and integrated approaches, making sure that the needs are met and ensure social inclusion processes and participation in all policies, meaning that this is not only a place in social policies or for the labor market, but we also need to ensure that social inclusion is ensured in health policies, in all other policies which are at place. When looking to the integrated care and harm reduction programs, how to ensure social inclusion processes there, we need to more address diversity in communities and multiple needs. People are also in the harm reduction community. We know that there are different needs. We talk about people who are homeless. We talk about sex workers. We have gender issues. And I think we need to be aware that here as well, one size does not fit all, but we really need to be sure that we can somehow approach that all. This means away from a supply-oriented approach towards a more client-centered one, more cooperation between services and interventions, and the development of complementary services. And a very important one, that we need to ensure participation and peer involvement and community-led initiatives to support them more actively, to really get people away from the passive position more into the active position, and really acknowledging the fact that communities have a lot to bring in. And last but not least, I think it is important to monitor and evaluate the effectiveness of services and interventions through participatory research and really looking into how our policies, how our interventions being experienced by the groups which are actually for whom they are designed for. This was the end of my very short and brief intervention. I would like to thank you for listening. If you need more information, please contact me through the email address or check the websites for more information. Thanks for listening.
Hi, my name is Kerry Brennan. I work with Cork and South East Simon community in Ireland, and I've been asked here today to talk to you just briefly about harm reduction in homeless services, and particularly with relation to harm reduction as a guiding principle and a key characteristic of Housing First services. So I am just going to run through some very brief slides, just looking at what a culture of harm reduction looks like in homeless services, some practical harm reduction interventions, a brief overview of the Cork Housing First and Waterford Housing First service, and just comparing implementing harm reduction in congregate settings such as emergency shelters or group housing versus harm reduction measures in service such as Housing First, where a person has their own accommodation and their own front door, and you can tailor interventions to the single individual. But I don't want to spend too much time on any of those slides. I'm more than happy to make the slides available to anybody who might be interested in the detail of those issues, and of course to answer any questions in the Q&A if anybody wants to know more. But I'm just conscious that we have very limited time for each presentation, and what I really want to be able to give time to is looking at housing as the single most impactful harm reduction measure that can be provided for a person who is experiencing homelessness. All of the many ways in which having safe, secure, stable housing drastically reduces or eliminates all kinds of harm and risk from a person's life. And also the way in which housing can be a stable base from which people can begin to look at recovery, look at contemplating positive change in relation to their substance use or any number of other areas, including reconnecting with things in their life that give them meaning and joy and a positive way to spend their time. So I want to finish with a couple of clips of some of our service participants telling in their own words what it's meant to them to have a home of their own and how they have reconnected to some of those things in their lives that they had previously lost touch with during their experience of homelessness. So in terms of developing a culture of harm reduction, I think it's useful to think of it in terms of recognizing those things that don't need to be earned through sobriety or compliance with treatment. And that includes basic things like access to a service, respect, positive regard, trauma-informed help and support without judgment, recognition of the person as more than their problems, celebration of successes, empathy when things go wrong. And of course, in terms of Housing First services, recognizing the right to have a home as something that does not need to be earned by sobriety or compliance with a treatment program is absolutely core to the ethos of Housing First. When we look at harm reduction practices and practical interventions in homeless services, I think a lot of the specific interventions will be familiar to many people here. So again, I won't spend much time going through them, but they include things like advice and support on safer use of alcohol, safer use of drugs, safer sex, provision of equipment to enable safety, everything from condoms to needle exchange to looking at provision of naloxone, access to methadone programs, looking at nutrition and hygiene, brief intervention and motivational interviewing, and providing opportunities for positive use of time. I'll just briefly describe the services that I'm here to talk about, which are the Housing First services in Cork and Waterford. These are part of a national rollout of Housing First across Ireland as part of a national implementation plan, which has been introduced by the Department of Housing, the Department of Health and other government offices. And in Cork and Waterford, they are delivered as a partnership between Cork and South East Simon, Focus Ireland, which is another NGO, the Health Service Executive, and the local authorities, so the city or county councils in Cork and Waterford. The services are focused on the people who are longest term homeless with the most complex needs and who have histories of sleeping rough or who are currently sleeping rough. We have an overall target of establishing 114 tenancies over 3 years, and we've established 80 so far. There's a very high success rate, which is typical of Housing First services. There's a tenancy sustainment rate of 88%, despite the fact that we are housing people with no preconditions and specifically prioritizing those with the most complex needs, people in active drug and alcohol use, people with mental health difficulties. The biggest barrier and difficulty to the progress towards the target in Cork and Waterford and across Ireland is the very difficult housing market and housing crisis that we unfortunately are in at the moment, which includes an extreme lack of availability of one-bed properties. I'll just turn briefly to the differences between working to a harm reduction approach within a congregate setting like an emergency shelter compared to how harm reduction can work in Housing First. I think the main point I'd like to make is that no matter how great the will is to work to a harm reduction approach in a congregate setting and how welcoming a service may wish to be of people who are in active substance use, when you're accommodating a number of vulnerable people in one setting, you necessarily have to take account of the impact that people have on one another. And so there are times when exclusion of a person who is under the influence or mentally unwell or exhibiting behaviors that others might find intimidating or frightening or threatening, a person may have to be excluded for that reason, despite the intention of the service to operate to a harm reduction approach. Whereas in a Housing First service, the person, has their own accommodation, their own apartment or house. You're meeting them in the community or during home visiting. And so the service, can pull back if it needs to pull back, and it can intensify if it needs to intensify. But access to safety and warmth and shelter for the person isn't in question because they have their own home. And that brings us to something that I really would like to highlight I think sometimes the most obvious points are the most important ones to make because otherwise they can be forgotten. They're so obvious that they're easy to overlook. And so I just want to spend a moment to look at just some of the many ways that housing is harm reduction. As you can see, I ran out of room on the slide. I think that if we had the time to brainstorm together and if we had more space in the presentation, we could probably come up with 3 or 4 or 10 times the number of points that I was able to list here about the ways in which having a home reduces harm, reduces risk, restores dignity, restores a sense of safety. So I'd just like to play a short video now of some of our service participants talking about the difference that having a home has made to them.
I've definitely changed. I've had this about 6 months now. The heating is working all the time. Showers in there with the toilet and sinks. It's all in there. It's on mine. The best thing, it's got everything I need. And one night here, I'm an alcoholic. And I've got my own garden and it's kept clean and all that. I can buy a drink out the shop, I'm allowed to, and come home with my shopping and all that. That's one of the key workers. I don't mind him, he's alright. He helps. He's pleased how I keep this place reasonable. I don't do it all myself, I wouldn't say I do. But I try to. To my eyes, I'm happy enough. Because I've got everything in my own way. Everything's there. When I want to go to sleep, I'll just lock my door, make sure that's locked. Nobody bothers me. So,
I was homeless myself for 15 years, I'd say, on and off in a sort of a circle that was keep repeating itself. There was always mayhem and chaos always in my life, and just nearly coming up to a year ago I moved in. Peace of mind is priceless, and having a house is definitely a peace of mind. Things are going forward since I moved into the house, like, and building new
Hi, we are Bianca Di Rosario and Kristof Bryssinck from Adviespunt Verslaving. We are a supportive service for people who use in Antwerp, Belgium. We would like to thank you for joining us during this workshop, and we'd also like to thank the organization for giving us the opportunity to share our experience and hope it can inspire you in your daily work.
Yes, I would like to enlighten you about where we are situated with some figures and facts. Antwerp is the biggest city in the Flanders region with about 530,000 inhabitants, and there are a lot of differences in the various districts. We give you also a very cautious estimation about substance use in our city. We estimate that there are about 25,400 problematic users of alcohol. And for the illegal substances, there is an estimation that there are about 4,800 people who use illicit substances on a problematic way. For non-substance addiction, we don't have figures, but also a very cautious estimation, and it is about the same magnitude than the problematic use of drugs and alcohol. So we are a citywide cooperation project between 4 NGOs. ADIC is an inpatient service provider, and Free Clinic, VAGA, and the Sleutel are 3 outpatient services. We are united in Adviespunt Verslaving, and it's our supportive service for people who use. Together, we have a much stronger voice towards our local policymakers. We work in a multidisciplinary team with psychologists, sexuologists, educators, a nurse, therapists, and a social worker in family care. It guarantees the different angles of perspective that are taken in account to find the answers to the questions for our clients. Who comes, rings, and mails our services? So, in this year, we already have seen 3,290 persons who used our help. They were calling, mailing, or coming face-to-face. About 376 people we saw face-to-face, and we were able to, for 270 youngsters, to prevent that they had a criminal record for possession on personal use or personal possession of illicit drugs. We saw about 103 women at our services, and we also saw 61 people who live with persons who use drugs. And that brings us to our next slide. People who live with people who use drugs. You should use them, foster them, cherish them, and support them. They make your therapy work. You're probably 1 hour in a week around your client. Meaningful others are 167 hours with people who use drugs. They help people who use drugs to reach the end of the tunnel, and even better, they make people who use drugs feeling that they are not in a tunnel. You make them feel that they are a meaningful part of society. And that's what recovery means. Get people connected, let everybody feel they are part of something bigger. Make everybody feel that they do matter. And that's exactly the overwhelming added value of meaningful others that we never can deliver as a service provider. Our strength as a service provider is our presence and availability, and that should be our core business. So we also should support people who work with people who use drugs, because we know all, we can't save the world on our own. Not for the climate, neither for social, psychological, or health issues. We need the social services, and more exactly, all the boots on the ground we can get. To share the load and to multiply the results. Together we can create and co-create synergy. We have to avoid the creation of parallel circuits. Normalization and generalization works in 2 directions. It should be normal for people who use drugs to use the regular services. And it should be normal for regular services to include people who use drugs. What we don't know, we fear. Our task is to make social frontline workers feel more comfortable in working for people who use drugs, and make people who use drugs feel more comfortable to use regular social services. We offer support and advice for social service providers on client case level and on organizational level. We try to reinforce and strengthen their teams of social frontline workers.
now to talk about the social determinants of health. So a study shows that physical and social environments are critical in the adoption and continuation of addictive behaviors. This means that behavior cannot be addressed without considering the environment in which the individual lives, works, and plays. One of the most effective approaches even appears to be trauma-informed care. So it's not surprising that interventions focused solely on changing the individual behavior have been insufficient to reduce substance use and addiction. So in our supportive service, we explore the different social determinants when a person comes to us for advice or help. We will try to make an estimate of what the person needs to reduce or stop usage. It's not uncommon that we refer someone to an organization that guides people to work or housing or financial services instead of focusing on the addictive behavior. The focus of our service is to work person-centered. So when you talk about harm reduction, it's often about illegal substance. Strategies like heroin-assisted treatment and needle exchange and so on are presented as harm reduction strategies. The goal is often to improve the health outcomes of vulnerable populations. But what about how to experiment or use recreational in a responsible way? Prevention programs, which approach substance use often with abstinence and avoidance, have been utilized to target, for example, youth. These strategies fail to acknowledge and address social contexts of use for youth. So a study suggests a shift in framework of school-based substance use education. The study points to the importance of contextually relevant harm reduction programming because youth are already engaging in harm minimization strategies of substance use within their local contexts, but on an informal basis. Therefore, an integrated approach of prevention and harm reduction would be more suitable. Research also discusses harm reduction strategies for behavioral addictions. A study talks about responsible gambling because of the major psychosocial and mental health consequences. Enforced breaks and messages are suggested as harm reduction strategies to promote self-regulation. Studies have shown a reduction in irrational gambling-related thoughts as well as the spent amounts. So based on these studies, it's not crazy to say that in our supportive service, we implement harm reduction strategies at any stage of substance use or behavioral use. Whether someone wants to use recreational or experimental, we will guide people to use responsibly. This way, people feel heard in their wishes and get the chance to talk to a professional instead of just going along with peers and not knowing the consequences. This also adds to the health benefits and quality of life of a person. Now, the catch-22. In our service, we've noticed that there are still too many obstacles to overcome to find the most suited treatment for someone. When someone asks for help with for example, a behavioral addiction, there is almost no option for inpatient or outpatient treatment. One of our partner organizations allows people with solely a behavioral addiction, but experience tells us that they feel as if they are out of place being surrounded with substance users. And of course, there is the challenge of waitlists. It's often a difficult path finding any help for people with behavioral addictions because of a lack of specialized professionals in certain themes. So they often end up in generalized help where they miss the specific difficulty of their addiction. It's even more difficult to find an answer in the case of mental disability and addiction. The question also rises whether someone will benefit more from generalized psychiatric help or specialized drug treatment. In cases of addiction, there is almost always a comorbidity with psychiatric problems, for example, depression, anxiety, trauma, which psychiatric help would be beneficial for, but there is also the need for a specialized drug treatment. More and more research argues that comorbid problems should be treated simultaneously with addiction. We often have to emphasize a particular problem to get someone signed up for treatments, to get someone in treatment. In specialized drug treatment programs, we tend to perceive addiction as a problem on its own, whilst a generalistic approach tends to focus on the psychiatric problems. What we should do is educate or support each other so we can grow to an integrated approach and connect with each other as health practitioners, as a society, just like the conclusion that is being made in MedPark, an integrated approach instead of individualized and separate. Thank you for listening and watching our presentation. If you have any questions or remarks, you can always contact us at hallo@advies.verslaving.be.